Hello Health on LAE is presented by the Ochsner Health System, a nonprofit, academic, multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 7 hospitals and more than 35 health centers located throughout Southeast Louisiana. Ochsner, healthcare with peace of mind.
We call it our More Money to Spoil Our Grandkids plan. With a Humana Medicare Advantage health plan, we get tips on how to make our money go further. We even get a health, finance, and benefits statement called Smart Summary that helps us find even more ways to save. And we like more.
More of what you want, because you deserve more.
I'm Tom Bagwell, and welcome to Hello Health, a partnership with LAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight's topic, allergies, and our guest is Dr. Lawrence Montelibano. In the second half of our program, we're going to be taking your questions live by phone at 504-866-3200. That's 866-3200, or you can send us questions by email at hhquestions@wlae.com. Dr. Montelibano did his undergraduate work at Stanford. He received his medical degree from the LSU Health Sciences Center. He also did his residency training there and served as chief resident in pediatrics. He completed his fellowship work in allergy and immunology at LSU, New Orleans. His special medical interests include treating patients with eczema and evaluating patients with recurring infections. He is a graduate of Isidore Newman High School, and it is our pleasure to welcome Dr. Larry Montelibano to Hello Health. Great to have you with us on the program.
Thanks for having me.
Yeah, tell us a little bit about your family first. You have 2 little ones running around,
Two little ones, 2 daughters. Mia is 3 years old, and Margot just turned 11 months.
Okay, got to keep you busy?
Yes, definitely.
All right, starting to walk, but not kicking a soccer ball around, something you did at Newman, right?
Exactly. We're working on it.
Okay, very good. Well, what was it, or who was it, that got you interested in the field of medicine, and specifically in this area, allergies?
In terms of medicine and pediatrics, I have to give a lot of credit to my mother. She's a pediatrician, now retired. So growing up, she was a good role model for me, I guess, professionally as well as personally, like a lot of mothers are. In terms of allergy, I myself was an allergic child, so I was a kid who was always sneezing, rubbing his eyes when he got near the grass, cutting the lawn. I ended up taking allergy shots for a few years, and that did help. Now I can play soccer, run around in the grass, no problem.
Very good. So in your case, you outgrew the allergies.
Yes, and I think the allergy shots did help me.
Okay, and we'll talk about all that coming soon. Well, let's start off with a basic definition. An allergy is what?
So there are a lot of definitions for allergy. One of the basic definitions is an allergy is an abnormal or exaggerated response of the immune system to a substance that is in itself not really harmful. So an example is something like an oak pollen. Oak pollen is not going to make a non-allergic person sick. Its job is just to help propagate more oak trees. But for someone who's allergic, exposure to oak pollen can cause them to sneeze, itchy eyes, and as well can cause them to wheeze. You can compare that to something like a bacteria or a virus, where their jobs as organisms is to kind of wreak havoc on us, and that's what they're meant to do.
It can certainly be more serious.
Yes.
Why are some of us allergic to some things and others not?
There's a big genetic component. So you see that allergies do tend to run in families. So when we talk to patients, getting a family history is a very important part. We don't have all of the patterns of all the allergic diseases defined completely, but we do know that there are familial tendencies.
What are some of the most common allergic conditions?
Some of the most common allergic conditions that I spend my day seeing are eczema or atopic dermatitis, food allergy, asthma, and allergic rhinitis. You can see on this this diagram here that the different size circles and how some of them overlap. There are some people who may have all of these. So a child who grows up with food allergy and eczema is at some risk for having asthma and allergic rhinitis as well. But there's a lot of variety. There's some people who may just have one allergic condition. Others may have two, but some people are at risk for having all four or several at the same time.
Before we move on, let's take all four of those individually first and explain some of the common symptoms and maybe what causes some of these.
So starting kind of from birth onward, what tends to present early in life would be something eczema or atopic dermatitis and food allergy. Eczema, a lot of you, with children may be familiar with it. It's very common, a condition, dry, itchy, inflamed skin. Children can't sleep at night because they're always kind of scratching themselves, and that can be tied in with food allergy. Common foods, milk and egg, can be triggers for eczema. Allergic rhinitis, we're all familiar with kind of spring or seasonal allergies. The runny, itchy eyes, sneezing, runny nose, nasal congestion that drives a lot of us around here crazy in the spring when the oak trees start to bloom. And asthma, similar to allergic rhinitis, but affecting the lungs, causing wheezing, difficulty breathing, shortness of breath.
Of course, our humidity is much higher here than in most places.
Yes.
Does that have an impact on allergies?
It does. It does. Our warm, humid climate kind of promotes the growth and propagation of a lot of common allergens. Dust mites enjoy humidity. The warm climate, the fact that we don't have hard winters, kind of allows plants that pollinate grasses to kind of thrive for most of the year. So that's a perfect setup for a lot of common allergens.
I hadn't heard this term before, but what is the allergic march?
So the allergic march kind of refers to the natural history that we see in a lot of in the presentation of common allergic conditions. So within the first couple of years of life, as you can see on this image on the screen, food allergy and eczema or atopic dermatitis tend to be the first to present. And allergy to food, because that's what you're exposed to. So, as a child starts eating, gets exposed to different things, there is potential to have an exaggerated response to the various foods that that children are exposed to. You can get hives, trouble breathing, different rashes, and again, eczema or atopic dermatitis can also be triggered by sensitivity or allergy to foods. Some of the other things, allergic rhinitis and asthma, they tend to present later in life, in large part because those tend to be triggered by pollens or inhaled allergens, some of the outdoor allergens. And a 2-year-old or less than 2 years old, most of them just don't spend as much time. So it's as you get older and you're spending more time outside, you've been through a few cycles of different seasons of the year, you get a chance to become sensitized or develop that allergic response. And that's why the allergic nose, allergic rhinitis, and asthma tend to present later in childhood.
Okay. Before we move on, we talked about these in most cases not being serious issues, but we've all heard of children who are allergic to peanut butter or peanuts, and in some cases it can be very serious, right?
Yes. So, allergies in general, it's a wide spectrum, and it's hard to tell what a given person's reaction is going to be. So on the one hand, seasonal allergies, a lot of people, they never see the doctor. They just take a little bit of Claritin or some over-the-counter medicines and then they do fine. They deal with it. But there's also a range, like you mentioned, peanut allergies where, minuscule exposures can trigger serious reactions, trouble breathing, closing of the throat, and, ultimately death. And those are the rare occasions, but we need to exercise our due caution and try to identify people who are at risk as best we can.
Well, doctor, give us an overview, if you would, and we have 3 images here to present of the conditions that make up the allergic march.
Okay. So I think the first image we're going to see is a picture of atopic dermatitis or eczema. As we mentioned, we talk about the dry, inflamed, and itchy skin, and you can see on these diagrams here, if you look at the lower one in the middle of your screen, in an infant, the rash can present anywhere. It can be on the stomach, on the back, on the face, as well as the arms and legs, and the rash can look like a variety of rashes. There's not necessarily one characteristic rash, but one of the cardinal features is itching. Some people call eczema the itch that rashes. So if it doesn't itch, there's a good chance that it may not be eczema that we're talking about. As children get older, you can see the image there on the top left of your screen. The eczema may more commonly affect what we call the flexural areas, or where the arms and the knees bend. So behind the knees, on the top right there, you can see behind the ears is another place that's often affected. Children are rubbing their ears, tugging their ears. So it's a common condition. A lot of children are diagnosed with kind of small patches or eczema at some point during their childhood. A lot of the eczema or atopic dermatitis that's really driven by allergies is more severe, and they might have greater involvement. And those are the kids who are really having trouble sleeping, need different kind of medicines to help them sleep. Those are the children whose skin condition is more likely to be triggered by maybe a food allergy or something like a dust mite allergy. So identifying that and minimizing their exposure to those triggers can kind of eliminate the need for so many medicines. So, avoidance is key in allergy. It's one of the things we talk about treatment, but if you can avoid the trigger, that's often more helpful.
Treatment isn't necessary.
Exactly.
Right. How about allergic rhinitis?
And then so allergic rhinitis, again, as you tend to get older, and children might present as early as 3 or 4 years old. Rather than food, the common triggers are pollens or inhalant allergens. Other than pollens, there are things like cat dander, dog dander, so pets, cockroach, as well as a common allergen a lot of people don't realize, but cockroach particles are also common triggers. This diagram here, what we're looking at, if you can see those small yellow circles, those are pollens. In this case, let's just say oak pollen. And when you first get exposed to oak pollen, whether it be in your nose or your eyes, an allergic person is going to produce antibodies to the oak pollen. The antibodies on the image there are kind of the purple little Ys or propeller looking things. So you see those get produced upon first exposure to the pollens, and those antibodies will connect to those larger purple circles that you see there. And then on a second exposure, the second time you get exposed to, let's say in this case, oak pollen, those pollen particles will attach to those allergic antibodies. And when it links those antibodies from those mast cells, those purple circles, gets released histamine and other chemicals that kind of trigger the allergic response. The runny nose, the sneezing, the itchy eyes.
And simply putting it, it's the body fighting against something it really doesn't have to fight against?
Exactly. So oak pollen in itself, to a non-allergic person, you can pour it all over them and nothing happens. But if you're, so unfortunate as to be sensitized, that can be, not only just inconvenient, but in the case of asthma, potentially life-threatening.
And then asthma itself, we have the third image to show.
And so asthma, it's a similar process as what occurs in the nose. If you look at this diagram here on the bottom right, you see a normal bronchial tube, nice thin walls. It's open, so a lot of air can move in and out of those tubes. The allergic response in the lower airways, in the lungs, that occurs with asthma, it's like instead of having the runny nose, you're having a lot of extra fluid in your bronchial tubes, and that can make it more difficult to breathe. Instead of getting nasal congestion like you do in your eyes, the walls of your breathing tubes, of your bronchioles, can get thicker, making it harder to breathe. And let's say instead of sneezing, those tubes can kind of twitch. When they twitch, they close, and that contributes to the wheeze. So similar process, but happening in the lungs. And whereas a lot of people just kind of deal with their allergic rhinitis, the allergic nose, the itchy eyes, if someone has asthma, that is more serious and can really potentially be life-threatening. And that accounts for many more visits to the ER, days of school and work missed.
I'm looking at those two tubes and I'm thinking of coronary artery disease, which I know builds up over a long period of time.
Right.
What about asthma? How quickly do we go from the clear tube, easy breathing, to highly congested and having a tough time?
Well, with asthma, we went over the three kind of cardinal components of asthma. One is the increase in secretions, and that can be temporary, that can come and go. Two is the spasming or twitching of the bronchioles, and that kind of comes and goes. But that third part, when you see the thickening of the airway, that is what happens over time. So poorly controlled asthma, if it's not treated over time, those walls will continue to get thicker and thicker, and you worry that you can have some irreversible damage there. And so as you get older, your lung function may be permanently compromised.
How are food allergies, eczema, allergic rhinitis, and asthma related to each other?
So with a lot of the common allergic diseases, on a cellular level, the mechanism is the same. What's different between the diseases is what organs are affected and what are the allergic triggers. So, for example, with food allergy, it could be your skin is involved. Someone eats shellfish, it gives them hives. It gives them so their skin is involved. Another person, their reaction to a food to which they're allergic might also be wheezing, so involvement of their airways, as well as closing of their throat, or fluid leaking from their blood vessels, creating low blood pressure, and that would be a serious anaphylactic reaction to a food. With allergic rhinitis, as we mentioned, it's the pollen that's causing it. And so what the diagram showed was just the release of histamine and other mediators to cause different adverse effects. What differs is essentially what organs are involved and what are the triggers.
Okay. Is the incidence of allergic disease increasing, and if so, why?
There's a lot of good evidence and there's a lot of studies out there demonstrating that, yes, indeed, allergic disease has increased over the last several decades, especially in developed countries. The image that we have here is of atopic dermatitis. This is actually a study done in the United Kingdom. But in essence, it shows very clearly that over the last few decades, the slide may be a little bit dated now, but the prevalence of atopic dermatitis is increasing. It's not hard to find similar slides that show the incidence of asthma increasing in developed countries, the incidence of food allergy, prevalence of food allergy increasing in developed countries. Why is it occurring is not definitively known, but there are a lot of theories. In developed countries, there are thoughts that maybe pollution, things like secondhand smoke, may be playing a role. On the one hand, there's also common theories that we're in essence too clean, and the fact that we're so developed is actually making us more prone to develop allergic disease.
I was going to say the commonality there in both pieces you mentioned was developed countries.
Yes.
Do we see this trend in underdeveloped countries?
Well, that's one of the comparisons, is that there are a lot of kind of comparison epidemiologic studies that show in developing or underdeveloped countries, the prevalence of allergic disease is actually less. One of the common comparisons when you look at East and West Germany. So East Germany initially was less developed than West Germany. When the wall came down and East Germany became kind of a more progressive or developed nation, they saw that the incidence of allergic disease actually started to increase. And then when you look at, say several Southeast Asian countries, you see there's a lot more parasitic disease and infections like that, but you just tend not to see quite as much allergic disease in terms of the allergic rhinitis, the asthma, and the food allergy.
So the allergists were saying Mr. Gorbachev, rebuild this wall.
Exactly.
Is that right?
Exactly.
What is the hygiene hypothesis?
So the hygiene hypothesis is kind of what we're touching on now, and it's saying, is this increased cleanliness, the smaller families, the immunizations, the increased use of antibiotics, are all these things actually making us more prone? Looking at the image here on the screen, if you look down at the bottom, there's the kind of the letters TH1, and then on the other side TH2. Those are two different types of immune responses. A TH1 response is a response that's more geared towards fighting infection, bacteria and viruses that can cause us disease, whereas the TH2 immune response is considered kind of more the allergic response. What the hygiene hypothesis kind of puts out is that at birth, you're delivered into this world that tends to be filled with microbes and bacteria, things to challenge your immune system. The developing immune system wants to fight those infections, and that's what the immune system's job is. Mm-hmm. And so by doing that, then it kind of puts the immune system in a position where it's ready to fight bacteria. In today's world, with vaccines, antibiotics, and smaller families, so there's not enough big brothers and big sisters to make a newborn child kind of get all those colds, the immune system is in essence bored. So does a bored immune system just kind of turns on things that, like we mentioned before, are otherwise not harmful, like pollen, like dust mites, and causes us, disease or conditions that may not have been there several decades ago.
Like a football player waiting to get in the game and finally gets his opportunity, and he's going full speed ahead, right?
Exactly.
Or soccer player in your case. Our guest is Dr. Larry Montelibano, and tonight we're talking about allergies. You can call us right now, and now's a good time to call, 504-866-3200, 504-866-3200 with your questions about allergies and the immunodeficiency, or you can email us your questions at hhquestions, HH of course for Hello Health, hhquestions@wlae.com. Well, doctor, is there a way to prevent allergies? Anything we can do to keep them away?
So starting from birth to minimize the chances that, let's say, your child will become an allergic child, the data that's out there, one of the best things you can do is exclusively breastfeed your newborn child. So there's good data that says exclusive breastfeeding for the first 4 to 6 months of life can prevent or at least delay the onset of eczema, and some studies support that it can delay the onset of wheezing as well. So there's numerous studies about all the benefits of breast milk and breastfeeding and bonding with mom, and the immune benefits, the protection for the immune system that breast milk provides. Breast milk also kind of presents mother's food in a way that is least likely to be allergenic or to provoke an allergic response in the baby. Another thing going along with that is delaying introduction of solid foods until 4 to 6 months of age. When a baby's born, the gut is still kind of immature, and introducing food too early can make it a little bit more likely that the food gets presented in a manner through the gut that is more likely to create an allergic response. So don't rush on introduction of solid foods.
Good tips. Are common allergic diseases outgrown, most of them?
So a common question I'll get is, my child has eczema, atopic dermatitis, which is a chronic condition. It can last months and years, but we do know that the majority of cases are outgrown later in childhood. Common food allergies such as milk allergy, egg allergy, soy allergy, those are also outgrown, usually by what we say school age, so the range of school age. Other things, shellfish allergy, nut allergy, those are less commonly outgrown. Allergic rhinitis and asthma also more likely to stay with you a little bit longer.
Okay. How do you test for allergies? And please tell me you've made some progress since the old needles in the back, but really it's still the gold standard, right?
It's still the gold standard, and I think we have an image here of what the skin tests look like, and if you can see that that a person on the left is probably not having too much fun, but what we call a skin prick test, or a lot of people call it a scratch test. What we're doing with that test...
Or hell on earth. But
exactly.
But go ahead.
Well, I'm not coming back to see this guy anytime. What you're doing in that test is you're taking some of the commonly allergenic proteins, and with little lancets, in our case, a picture of which is on the left there, you're just barely breaking the very top layer of the skin. So it's not a needle, it is literally just a little scratch. You introduce those allergic proteins to the skin, and you wait about 15 minutes. And what you're looking to see is, does this person have allergic antibodies for those particular allergens? If they do, you're going to see a response like that, what we call a wheel and flare reaction, or what most people looks like a mosquito bite.
I'm going to ask you here, as I look at the image on the right, I see all the redness. Is that because this is someone with eczema already, or is the rash or red caused by the skin testing?
Everything you see there is caused by the skin testing.
Okay.
And what you cannot tell, a lot of people ask, but what you can't tell looking at that person's back, you can't tell if that's a person with eczema, a person with seasonal allergies, allergic rhinitis, or a person with asthma. That test just says, yes, that person has allergic antibodies to whatever allergens those correspond with. And so testing alone only tells us so much. An important part of what we do with allergies is take detailed histories, and you have to match the histories with the tests. A lot of people ask, you said that test doesn't look like too much fun. We do have blood tests now where you can do a blood draw and test specifically for common allergens: oak, dust mite, cat, dog, milk, egg. So if that's not your cup of tea, we can do a simple blood draw and get the answer there if there are allergic antibodies in your bloodstream.
And with children, there's a lesser test, right, that you can use with
yes.
Probably less pain,
right.
Less pricks.
Right. So with an adult, if you came in, I would test you kind of similar to that picture. It might be 60 common allergens. With the toddlers and the younger children, we have a smaller panel of about 20 or so of the common allergens, and it's a little more humane and tolerable for the kids.
Quickly tell me about how allergies are treated today. You talked about Claritin,
yes.
and most of us know all about that. What are some of the other treatments that you're using today in your office? So
common things, as you mentioned, are the antihistamines. So that would be the Claritin and Zyrtec and the Benadryl. And those are mostly for the itchy eyes, the runny nose, the hay fever type of symptoms. Other things are topical steroids, or small amounts of steroids used appropriately. Many people have heard of the common steroid nasal sprays that are used out there. One of the common treatments for asthma is daily inhaled steroids, and for difficult to control eczema, topical steroids are commonly used. A lot of people are rightly cautious about using steroids, but a lot of the medicines are out there are dosed appropriately. So it's small amounts of daily steroids targeted just to the organs where they need. If you just have eczema, we'll just put it on your skin. If you just have an allergic nose, you just use it on your nose. Asthma, just your lungs. So we're minimizing the systemic exposure to steroids. Other things to consider are, in terms of treatment, a lot of people have heard of allergy shots. I think I mentioned earlier. So with allergy shots, what we're doing is we're actually kind of injecting you on a weekly or regular basis with some of the things that you're allergic to. So we start in small amounts and gradually increase. It's a significant time commitment. You need to commit to this for 3 to 5 years, but it's the only thing that actually really alters the immune system and ultimately hopefully makes you less of an allergic person. A lot of the other medicines we use are just kind of symptomatic treatment. And of course, we also mentioned earlier is avoidance. If you find out what you're allergic to and it's possible to avoid that, then that's half the battle right there.
Okay, 30 seconds left. There's a big reason we have big problems with asthma in New Orleans, right?
Mm-hmm. Yes. So perfect place for allergens. You can see on the image there, cockroaches, dust mites, and we know there's a lot of pets. Everybody knows there's a lot of cockroaches in New Orleans. I see people and I tell them they're allergic to cockroaches, and they say, I don't have cockroaches in my house. And I tell them, only half jokingly, you just don't see the cockroaches in your house, but we all know that they're there. And then outside, we know there's a lot of grass, trees, weeds, and everyone knows about mold after Katrina. So this place, in large part because of the warm climate, is just a perfect setup for a lot of our common allergens.
All makes a lot of